time, let me start with this. You can one thing I would like to tell you, please do subscribe to my channel, and if you go to my channel, you can find a playlist. I have covered, I think, gastroenterology, endocrinology, and rheumatology. So you can you are just one click away for more information. Just sit back, take a cup of coffee, and let me start with this SLE arthritis. Okay, the joint pain is one of the most common reasons for the initial clinical presentation of the patients with SLE. Arthralgia, myalgia, and frank arthritis may involve the small joints of the hands, wrist, and the knees. In contrast to the rheumatoid arthritis, SLE arthritis or arthralgia may be asymmetrical with pain that is disproportionate to the swelling. SLE arthropathy is rarely erosive or deforming. Characteristic hand deformities are swan neck deformities that result from a recurrent synovitis and inflammation of the joint capsule, tendon, and the ligaments. These deformities are usually reducible and non-erosive, resembling Jacquard arthropathy, which is non-erosive arthritis following acute rheumatic fever. Another important consideration is the increased prevalence of avascular necrosis in the SLE population related to healthy individuals. It may be due to SLE pathogenesis or concomitant heavy steroid use. So try to remember the cause for the AVN in a patient with the SLE. The most common affected site is the femoral head. Independent risk factor for AVN in a patient with SLE includes use of steroids or cytotoxic agents and the presence of arthritis. Arthritis of the proximal PIP, MCP joints of the hands as well as the wrist is the most common musculoskeletal finding in SLE. Tenderness, edema, and effusions accompany a polyarthritis that is symmetrical, non-erosive, and usually non-deforming. Jacquard arthropathy is the term used to describe the non-erosive hand deformities due to a chronic arthritis and tendinitis that develop in 10% of patients with SLE. Myositis may manifest as a weakness in a SLE but is more commonly related to the overlap syndrome or corticosteroid-induced myopathy. Fibromyalgia, distinguished as a myofascial tenderness without weakness, is commonly concomitant with SLE, causing generalized widespread pain, arthralgia, and myalgia. Very important, write it down or I'll replay my video again and again. Sorry. Okay, with the focal pain in areas such as hips, knees, and shoulders, consider avascular necrosis in patients who are taking steroids. Consider septic arthritis when one joint is inflamed out of proportion to all other joints or if fever is present. With arthrocentesis may be performed in a patient with the joint effusions, which can be inflammatory or non-inflammatory. So you can see both the things. The cell count may range from less than 25% of polymorphonuclear neutrophils (PMNs) in non-inflammatory effusions to more than 50% in inflammatory. Viscosity will be high in non-inflammatory effusions and low in inflammatory effusions. Gross appearance of these fluids will be straw colored and or clear in non-inflammatory cases, or either cloudy or yellow in inflammatory ones. So try to memorize that, try to write it down. And okay, now what is the treatment? Treatment that is not much different from other SLE. You have to treat the SLE, that's it. That is the treatment for arthritis. But in meantime, you can give NSAIDs, low potency immunosuppression medications beyond the hydroxychloroquine, or short course of steroids can help to relieve the joint pain. So thank you so much for watching my video. Please let me know how I am doing. If you have any questions, please contact me. Thank you so much for watching my videos. Thank you. Take care.